Okay. Alrighty, so this is for your Unit 5 exam. It's covering mostly respiratory and tuberculosis. And then thank you for putting your email in there. Um, if you guys haven't done this form, I'm gonna put it at the end as well, but if you can snag it real quick and fill out that attendance form, that would be great for me. And then also something a little bit different this week. Oops. I am just asking for some feedback. So I have had a really great time being your tutor this semester. This isn't the end. I am going to tutor you guys for your final, but nearing the end, if you guys could fill out this short form for me, it's completely anonymous. So if you have really mean things to say, I hope not. But if you do, you can put it in there, and I'm not going to know who you are. I'm also tutoring Patho 2 and Patho 1 again next semester, so you'll be seeing more of me. So if I can tailor it to work better for you guys, I would really love to be able to do that. This will also be available at the end as well, but your feedback, as you guys know, is like the best way for me to improve. So I would appreciate that as well. Alrighty, so you guys are so close. You are almost done with your very first semester of nursing school. Literally, what, like 3 weeks left? Like, that's insane. This is your last exam in this class before the final. So as always, please, please, please prioritize yourself. Make that time for what you enjoy, even if it's 10 minutes a day. Getting that adequate sleep and moving your body in whatever way that might look like for you. Um, and then also reaching out to your professor, your advisor, myself, or any other trusted person in your life, that we're all here to support you. I've gotten a few emails kind of heading into final season about support people need, and I'm super, super happy to help. I've offered a bunch of like group tutoring and study tips like on a one-on-one level. If you need anything, I just want you guys to know that I'm here for you as well. And then, like I said, I will be holding another review session prior to our final. The date and time is currently TBD, um, but stay tuned. I'm just trying to navigate my own finals and also working in this for you guys, but there'll be one, I promise. Alrighty, so starting off with the respiratory unit, per usual, here's a list of some good terms to know. I put the ones in bold that are like the most probably important, just to have a good understanding of. And not only like knowing what they are, like hypoxemia or hypoxia, for example, but kind of knowing like what effect that has on the body will help you be able to understand like a lot of the different mechanisms of action for these diseases. Labs to know, these are straight off of your guys' blueprint. Just kind of a good understanding to have of these. Alrighty, and then there's your pulmonary function test. This is a test that measures ventilation, so that air movement in and out of the lungs. It can assess for obstruction and resistance in the lungs. And then there are a bunch of different values to know. Um, but tidal volume, residual volume, total lung volume, and vital capacity were some of the ones that were kind of bolded on your PowerPoint for you guys. So I just picked those ones out. Again, it's kind of hard for me to tutor on these because it really is just term and definition. So with the labs, the terms, even some of the medications, things like flashcards would be good memory tools for that, to get these kind of down better, I guess. So then we've got COPD. This is chronic obstructive pulmonary disease. COPD is kind of broken down into two main disorders. There's your chronic bronchitis and emphysema. These are both obstructive disorders, and that basically means that in one way or another, they're limiting expiratory flow. So that obstruction in the disorder causes air trapping and decreased ventilation, which we'll talk about a little more, but that can cause hypoxemia, so low oxygen in the blood, as well as hypercapnia or excess carbon dioxide. Both of these conditions, COPD as a whole, is progressive, so it, gets worse with age and it will kind of continue to get worse and deteriorate. Um, and risk factors are they're kind of what you'd expect. There are some non-modifiable ones like age and genetics can play a role. But a big, big one is smoking, certain occupational exposures and environmental pollutants. Those are all modifiable risk factors that can um, impact someone's likelihood of developing COPD. As a whole, COPD kind of has some grouped clinical manifestations. A lot of it is just kind of what you'd expect when you think of a respiratory disease. You're looking at cough, wheezing, dyspnea, pursed lip breathing. And it's kind of interesting because I have worked with a bunch of COPD patients. I had never seen pursed lip breathing until this semester, and it was actually during my psych clinical, which is pretty interesting. But the patient had COPD, and I mean, he was breathing with his lips like pursed in an O. And I had never seen that before in practice. But they do that. Those uses of accessory muscles in breathing, a tripod body position, which I'm pretty sure, no, he's not quite doing it, but that's when you like kind of lean on your knees and brace yourselves on your arms. And then it can also come with right-sided heart failure as well. So the first type of COPD is that chronic bronchitis. This is the blue bloater type of COPD. I pulled the picture from your PowerPoint as well, just kind of depicting like what that can look like, and when like deciphering between blue bloater or the other one, the pink puffer. So I actually think those images are great to study off of as far as like clinical manifestations go. So these are characterized by inflammation of the airways. Um, to be diagnosed, the cough and sputum have to be present for 3 months in 2 consecutive years. It's most commonly caused by chronic irritation, so you can think of those irritants like smoking or someone who's super susceptible to infections and has dealt with a lot of that just irritation as a result of infection. And some unique or more notable clinical manifestations for chronic bronchitis is that dyspnea, activity intolerance. Cyanosis is kind of where you get that the I'm sorry, the blue bloater from, and then edema is there as well. I need to change that. Barrel chest is characteristic of pink puffers. I'm super sorry about that. Not blue bloaters. So I will change that before I go ahead and send this PowerPoint out to you guys. And then this, as well as emphysema, can lead to hypoxemia and hypercapnia, which I mentioned earlier. So here is that barrel chest I was talking about. It's depicted in the image on the right. Emphysema is the pink puffer side of COPD. And instead of like the inflammation itself in the airways, emphysema is characterized by like small destruction of the alveolar walls that result from inflammation. And because of that destruction, you're getting a loss of surface area for gas exchange to move in there. This one also does cause hypoxemia and hypercapnia, so that's kind of the same across the board as far as uh, I'm sorry, COPD goes. And then chest hyperinflation, that's where you get that barrel chest. We're going to talk a lot more like in depth with the medications coming up, but this is just like a quick list. Typically for COPD, you're looking at bronchodilators, those beta-2 adrenergic agents, corticosteroids, and supplemental oxygen as needed to get that SpO2 up. So that brings us to asthma. Asthma is the reversible and chronic inflammation of the airway. A lot of people have asthma. I'm sure you yourself or someone you know your age or in your family has asthma. I have two asthmatics in my immediate family, super, super common. So a lot of people have a good understanding of what asthma is, even if you're not necessarily going into healthcare. So asthma is caused by an exaggerated response of the bronchioles to varying triggers, stimuli. We're going to talk a little bit more about what those triggers can be. But the reaction typically causes inflammation, edema, obstruction, bronchospasm, so that like spasming motion of the bronchi, and then excess secretion of mucus as well. Asthma can be caused by genetics. Again, like I said, in my family, I think my grandma has asthma, my mom has asthma, and then my sister has asthma. So there's definitely that like familial genetic component to it. And then also some people are predisposed because of their environment. If like your job exposes you to a lot of chemicals or, your living area has a lot more pollen or other allergens, you might be at a higher risk of developing asthma. Those common triggers are going to be things like infections, those environmental things again, like pollen or dander, smoke even. My mom, like I said, she's an asthmatic, and if someone is smoking near her at all, she like immediately goes into a coughing fit and has to kind of like excuse herself. And then exercise, medications, and cold weather can also trigger these. Clinical manifestations definitely vary for asthma, and severity. Um, like mild asthma, you might see chest tightness, wheezing, and cough. And typically these people can be like symptom free for extended periods of time. Again, I'm using my family, but my sister, she can go months without having symptoms of asthma and then kind of go into a flare where she has kind of that recurrent episode of chest tightness and wheezing and whatnot until it's back under control. Severe asthma, though, is going to be pretty consistent. A lot more things can trigger it. And it is less reversible because it is just like chronically severe. That can involve additional symptoms like the use of accessory muscles, worsening dyspnea, and then louder wheezing upon auscultation. Status asthmaticus, I would definitely know about this. This is the acute and severe attack of asthma that's not responding to usual treatment. This is a medical emergency. So someone, they're having a severe asthma attack and their emergency medication is not working. This is when you would try to start seeking that emergent help. I thought this was interesting when I was learning about it. You would think that if the patient is no longer wheezing or coughing, that that would be a good thing because it would indicate improvement. But actually, that lack of wheezing or coughing is a warning sign in your patient, as it can indicate that there's just no more air movement or bronchoconstriction. And that can cause, obviously, like respiratory cardiac arrest, and ultimately death in this situation. So it's like you kind of want your patient to be coughing because that way you at least know that there's air movement. Peak flow meters, these are the best way to monitor and predict exacerbations. This is a great piece of education for patients because this is something that they can kind of monitor themselves as well. Results of a peak flow meter are divided into the red, yellow, and green categories. Kind of straightforward as far as what those mean. There's the danger warning, and then when you're in good control. And your personal best is that peak flow. Um, so everyone's is going to be different. But that can, if you're, 20% under your peak flow, then you know that compared to someone who's like 50% under their peak flow, then how severe like an exacerbation or oncoming exacerbation could be. And peak flow meters can predict, like it says, predict an exacerbation before they occur. I would definitely know that, and how these play a role in prevention as well. Okay, practice question. Also, I know there aren't that many people on tonight, so if people don't comment, that's totally okay. I'll just kind of go through the answers. Um, so true or false? COPD can cause hypoxemia and hypercapnia. Yep, well, why did we go backwards? Okay, yep, you guys are correct. This is true. Like I said earlier, I would know this and I would know what those signs and symptoms of hypoxemia and hypercapnia are and how they impact the body. So without doing blood work, could you recognize that this person is hypercapnic or hypoxemic, that kind of thing? Which of the following is false regarding status asthmaticus? Awesome. Yep, you guys are all correct. That one is C. I did talk about that one pretty specifically. But yep, that is not a good sign. That's a sign that their airways are closing. So it's not a good thing, but you'd want to see that wheezing and coughing in a patient in an asthma attack like this. Alrighty, so that was all I had for the pathophys. Now for the medications. I remember for me personally at this point in the semester, I was so exhausted, and for some reason, like learning these medications felt impossible. So, like, if you're there, I fully relate to that and I understand that. I would say just do your best kind of getting those key pieces about each medication. Do not try to like memorize everything in the textbook or your professor's material. Just pull out, what really is important, especially if you're kind of at that mental burnout phase. You got to do what you got to do to protect yourself as well, ultimately. So that first class is the adrenergic bronchodilators. These work to stimulate the sympathetic nervous system and then therefore involve adrenaline and epinephrine. There are two types of adrenergic bronchodilators. You have your non-selective class and your selective class. The non-selective class stimulates multiple receptors, not just, we'll talk about, but not just these beta 2 receptors. Um, so the main non-selective adrenergic bronchodilator is epinephrine. It's a short-acting medication used during acute attacks of bronchospasm. We know epinephrine from the unit we talked about allergies in. Um, so again, it is that emergency use and it's a high alert medication. And it can cause adverse effects like hypertension, tachycardia, restlessness, arrhythmias, and more. So you do have to monitor closely for those adverse effects, but ultimately, if it's going to stop someone's throat or airway from closing up, that's a super important. You have to protect that airway first and foremost. So then you have the selective adrenergic bronchodilators, which selectively stimulate that beta 2 only. So because of that, your selectives are going to be they're going to have significantly fewer adverse effects than your non-selective bronchodilators. Um, so there are three to know for this one. Your short-acting one is albuterol. This is the drug of choice for acute bronchospasm, as its onset is only like 5 to 15 minutes. So if someone's kind of having a sudden onset asthma attack, they can take an albuterol inhaler as a selective adrenergic bronchodilator and kind of experience relief relatively quickly. The intermediate acting one is the metoprolol inhaler. This one can work to treat acute bronchospasm, but it's also used to prevent exercise-induced asthma. So it's not going to work as fast as albuterol, but it does kind of last a little longer. So people can take it before exercise and expect to have those benefits, kind of during. And then lastly, the long-acting one is the salmeterol inhaler. This is a preventative medication that prevents bronchospasm and it lasts 12 hours and it is used prophylactically. So, someone could take it if they know they have a high activity day or maybe a day outside where they're around like pollen or environmental triggers. They could take this in the morning prophylactically and kind of protect their lungs during the day. So those were the adrenergic ones. Your anticholinergic bronchodilator is ipratropium bromide. This is a medication that instead of stimulating the SNS, it blocks the PNS, which causes bronchodilation and a decreased secretion of mucus. This is an inhaler, and this one is used for prevention. Um, for this exam with the medications, I would know like importantly, which medications are used for acute emergency situations and which ones are for prophylaxis or prevention. That'll definitely help your understanding as you like work through some of the questions. Something unique about this one is it contains soy lecithin, and the patient cannot take ipratropium bromide if they're allergic to peanuts. So checking for history of allergies is super important, especially with this medication. And then it can also be combined with albuterol in a nebulizer treatment called a duo-neb. The xanthines are another medical or medication class, sorry, for asthma. This is theophylline, and it's a second line drug primarily because it has a high risk for adverse effects and a very narrow therapeutic range. Similar to like meds we've talked about, like digoxin is another one with a narrow therapeutic range. Um, So with theophylline, you have to monitor that serum drug level to make sure they're not having like toxic levels of it in their blood. That 5 to 15 micrograms per milliliter is ideal. Um, Anything over 20 is considered toxic and puts the patient at risk for seizures. Corticosteroids, I'm pretty sure we've talked about before in this class. They are used primarily to decrease inflammation. And they can be used for a million different conditions in general. For this unit, though, inhaled corticosteroids are going to be for kind of chronic use for that prevention purpose. And the two main ones are beclomethasone and fluticasone. And then in acute situations like treatments of COPD or asthma exacerbations, you can give corticosteroids via IV. The main one for this is methylprednisolone, and this would be an IV push administered over 1 minute. So I would definitely know like inhaled versus IV and then what that entails for each one. Oh, we went backwards. I'm sorry. Perfect. Okay. Adverse effects with the inhaler form for that chronic prevention use. There is a risk for oral fungal infection, which we'll talk about more in a second. But the benefit of using the inhaler is that there's very minimal systemic effects because it stays pretty concentrated to the lungs. But if you are giving steroids that IV or PO route, there are some pretty intense and like it's an extensive list of side effects. You have generalized immunosuppression, so you're at an increased risk for infection. You can have growth deficits, fragile skin, edema, high blood sugar, and more. So definitely have to keep a few things in mind for a patient who's on IV or PO steroids. Um, for that fungal infection that I was talking about with the inhaled form of corticosteroids, something you can do to prevent that, to teach your patient, is to just kind of rinse their mouth out after the use of their inhaler so that that medication isn't just sitting in there, like in their teeth and whatnot. And nystatin, I definitely would know this medication. It's an antifungal. I cannot type. I'm so sorry. That does not say antifungal. It's an antifungal oral liquid suspension, and you would teach your patient to swish and swallow that medication. And that would be taken like after um, someone does a oral, or sorry, an inhaled version of a corticosteroid. And then if someone is taking it PO or IV, you have to taper the dose. You cannot stop a steroid suddenly, because it can cause like sudden adrenal insufficiency. So always taper. I don't know if you guys have ever had like those steroid like dose packs when you get sick, and like the first day there's like 6 pills, second day 5, all the way down to 1. You just always have to taper steroids, no matter what the situation is. Two more medications for the respiratory system. You have the monoclonal antibody medication, omalizumab. Guys, I'm doing my best. This is an adjunctive treatment for allergic asthma, because it works by targeting that IgE that we talked about a few units ago. Um, it's administered via injection 1 to 2 times a month, and it does have a black box warning of having a high risk for anaphylaxis. So because of this, it's given in a healthcare setting, especially in the beginning, when someone's taking it for the first few times. Then you have leukotriene modifiers. This is montelukast. This medication works to inhibit leukotriene, which is a substance released from mast cells that causes a lot of those symptoms like bronchoconstriction and mucus secretion. So in turn, this medication will decrease those. Montelukast is used for prevention of exacerbations, not for acute treatment. And it does have a black box warning for neuropsychiatric effects. Someone can develop hallucinations, delusions, suicidal ideation, those types of things from this medication. So that's definitely important to know. Spacers, these increase medication delivery to the airways and reduce the risk of oral fungal infections in turn. These are definitely great tools to give to people, to recommend and kind of explain how they work. Because in addition to those benefits, it can also help, kids or your older populations who have reduced hand dexterity because they're easier to hold and use than just like the small inhaler would be. Okay. Which of the following is a short-acting selective adrenergic bronchodilator? Let me make sure I'm staying on time here for you guys. Awesome. You guys are all correct. That's B. Um, Epinephrine's the non-selective one. Salmeterol's the long-acting. I need to change that as well. I'm sorry. And theophylline is that xanthine drug. What is the black box warning for montelukast? Yep, you guys are correct. That one is A. Which of the following is false regarding corticosteroid use in asthmatics? Awesome. Yep, you guys are all correct. I put the rationale in there, but they're used for prevention, whereas the IV meds would be used for acute treatment. Which of the following is the therapeutic range for theophylline? I keep looking to my left because my dog is laying on my bed and she got herself on top of a pillow and like that's just where she's sleeping. And she's like a small dog, so it's just She's just being funny. You guys are all right though. It's B. Alrighty, next we've got pneumonia. I'm sure a lot of us have heard of pneumonia before. Some of us might have even had it or had a family member who's had pneumonia. It's a restrictive disease causing inflammation of the bronchioles and alveoli. Similar to any infection that we've talked about, there are different classifications depending on where the pneumonia was acquired. So you have that community acquired pneumonia. That's when someone, you come into the hospital and within 24 hours of admission, you develop pneumonia. Because of incubation periods and that kind of thing, it would be known that the infection was acquired outside of the hospital, prior to that admission. Healthcare associated pneumonia, non-hospitalized but exposed in a healthcare facility. That hospital acquired pneumonia. Think someone who's been admitted for more than 48 hours developing pneumonia. And then ventilators associated pneumonia would be a ventilated patient who develops pneumonia after 48 hours of being ventilated. There are a lot of risk factors. I put a note in there. Understand like what types of things would put someone at risk for pneumonia versus memorizing this very long and excessive list. Um, yeah, that would be my advice for that one. For pneumonia, the clinical manifestations are super variable because they base off of the type of pneumonia, whether it's bacterial or viral, and then kind of how severe it is and what kind of like comorbidities the patient might have going on. But there's a list of some of the most common ones. We often talk about like crackles in the lungs. That's a big one. In your older adult population, they almost always have some symptoms that kind of make them unique from others. They might have a harder time with fevers. They might not develop a fever. Or, like a small change in temperature might be more severe. They can develop anorexia and kind of a mental status change. Those could be additional symptoms of pneumonia. Aspiration pneumonia then is pneumonia caused by aspiration or inhaling food or other foreign objects into your lungs. Patients at risk are going to be your patients with altered consciousness, those older adults, and people in general who have a decreased cough or swallowing ability, which can happen in just your post-op patients as well, or someone who's intoxicated with alcohol. I like to think about aspiration prevention. At this point, you've all been in your long-term care clinical setting, and you work a lot with like different diets and that like pureed food. That's all designed to prevent aspiration. So just keeping those things in mind. Atelectasis is the collapse of a small number of alveoli. These are most commonly caused by sedation and a post-operative status, which is why a lot of the times in your post-op patients or your hospitalized patients in general, you're going to encourage turn, cough, deep breathe. That's a trio that you always teach. And then incentive spirometer use also really works to prevent atelectasis. And this is kind of incorporated in this section because someone with atelectasis is at a much higher risk of then developing asthma. Sorry, developing pneumonia. Not. Um, so the treatment for pneumonia is dependent on the cause of the pneumonia. For example, if it's a bacterial pneumonia, you would give an antibiotic. If it's viral, you kind of are restricted to that symptomatic care. But as always, you can get those analgesics to kind of reduce pain and fever, or bronchodilators for the airway, those types of things. A specific medication, though, is acetylcysteine. This is a mucolytic used in the treatment of pneumonia when it's inhaled. We learn about acetylcysteine as an antidote for acetaminophen overdose, which is true, but not in the inhaled form. The inhaled form is going to be a mucolytic that breaks down those thick mucus secretions. Something unique about this as well is it's pretty specific to pneumonia because it is contraindicated in your asthma patients because it can cause bronchospasm. And in your patient who has asthma, they're probably already struggling with bronchospasm to some degree. So this is not a medication that you would want to give them. Alrighty, which of the following situations is depicting community-acquired pneumonia? Awesome, perfect. You guys are all correct there. That is the example of community-acquired pneumonia. Which of the following is false about acetylcysteine? Awesome. Thank you guys. You are all correct again there. Like I said, it's not recommended because of the risk for bronchoconstriction slash bronchospasm. Alrighty, we are on tuberculosis. I think this is a lot, I don't want to say easier, but more straightforward, easier to wrap your head around. I'm pretty sure, oh, we're going backwards. Alrighty, so tuberculosis, this is a bacterial infection characterized by a slow-growing bacteria that requires long-term and oftentimes intensive antibiotic treatment. And it is transmitted airborne, so you have to initiate those precautions. Some risk factors, those who are immunocompromised, those who use substances, people with those pre-existing comorbid conditions, areas that are overcrowded or homeless populations, nursing homes, prisons, these are all at a much higher risk just because rates of transmission would be insane just because you're very, very close to one another. And then also travel to high risk areas. That is another one there, which I'm going to talk about that more in a second. Then there's tuberculosis testing. We've all had to do this for the nursing program. We have to get tested for TB. Whether you do the skin test or the blood test or whatnot, we've all had to do it. So the skin test is measured by the degree of induration, not necessarily how much redness. So you get the prick, you go home, you come back, and they measure that induration, and that measurement determines whether or not you are positive or negative. This does not confirm disease, it just shows like the nature of the infection. And then after that, a sputum culture can confirm the organism's presence, and then you would run a sensitivity to determine what antibiotic could be the most beneficial for the organism. So this is why I keep like alluding to something. I have tuberculosis, and that's like crazy. Um, I did my test sophomore year for college for nursing. I'm a plan two, so I did it like at the end of sophomore year. And I tested positive and I was like, what? Like, what is happening? I genuinely freaked out in Dr. Wargo's anatomy class. Like, I lost my mind. I made a bunch of phone calls. I was freaking out. Like, I thought I was gonna die. I'm like, what do you mean I have tuberculosis? Long story short, I got latent tuberculosis from a trip I took to Peru in 2022. I went to Peru for a few weeks. I was in a city center and it's a higher risk area. That's why I mentioned traveling to high risk areas. Um, Acquired the microbe, didn't know, never got actively ill from it. And then fast forward, it would have been 2 years. I had to take a test for nursing and it came back positive. So I'll talk about it more like when we talk about the medications, but I did have to do a pretty intensive round of antibiotics. Again, I had latent tuberculosis, so I was never symptomatic, never contagious. But I had to do the full course of antibiotics to kind of wipe that out of my system so I didn't risk it becoming active and making me ill and contagious and all that. But yeah, that was a pretty interesting time. So I am super well educated on tuberculosis. If you have any questions for the exam, I should be able to help you out there. But sticking to the course material, latent TB, as I said, the patient has the microbe in their body, but the microbe is not actively replicating, not causing active disease. So, like I said, in the state, the patient is not contagious and will be fully asymptomatic, um, but they will test positive. Um, the issue is that it can be active and contagious at any point. So, someone with confirmed latent tuberculosis, if they start getting sick, they kind of have to go in and check and see if it's the tuberculosis or if they just have a cold. That activation can be triggered by a compromised host or just re-exposure to tuberculosis. And that's why treatment, even though it's latent, is recommended because you can kind of kill the bacteria before it ever has the chance of becoming active. So then the active tuberculosis is that active disease state. The person has symptoms and they're contagious. And this is when treatment is now crucial. Early symptoms of TB are fevers, super unique is night sweats, fatigue, weakness, weight loss, and a productive cough. I would definitely familiarize yourself with the symptoms. Later symptoms include all of those, and then adding hemoptysis and anorexia as well. So for the medications, isoniazid is a first-line therapy drug that's used in active and latent TB. Its adverse effects are hepatotoxicity, so liver toxic, peripheral neuropathy, and hyperglycemia. For nursing interventions for isoniazid, it can be given with vitamin B6 to reduce and challenge that neuropathy risk. Um, you can monitor, or you should monitor the liver function test, just because it is a potentially hepatotoxic drug, and then stop and report any signs and symptoms of liver damage. Rifampin. This is the one that I was on. It was not a fun time, you guys. This is a first-line drug for treatment of active tuberculosis, which again, I had latent, but this is course material. Um, it is a hepatotoxic drug. The really unique thing about rifampin is that it turns all of your bodily fluids bright, bright red and orange. Tears, urine, saliva, all of it is bright red, orange colors. If someone's a contact user, it can stain their contacts. Um, I was educated on this before I started rifampin, but I didn't expect it to like start immediately. I was on rifampin for 5 months in 2024, it would have been. Um, and literally the morning after my first dose, my eyes were like red and my saliva was red, and it really, really threw me for a loop. Um, that was not a fun time. It can cause GI discomfort. Super true. I struggled with that for the first few months. And then it also can cause pseudomembranous colitis. So your nursing implications, it's not on here, but you're gonna want to educate your patient about those bodily fluids changing colors because it can be super startling, but it is normal. And then with the other one as well, you're gonna want to monitor your liver function test and then stop and report signs and symptoms of liver damage and colitis. Pyrazinamide is another first-line drug to treat TB, often used in combination with another drug like the isoniazid. Adverse effects again are hepatotoxicity, GI upset, and gout. If you've noticed, the hepatotoxic thing is pretty common across a lot of these, and they all usually have like something that makes them a little bit unique from the others. This one causing gout. Just like the others, you're going to want to monitor liver function test and stop and report if there are any signs or symptoms of liver damage. Ethambutol is another first-line drug to treat TB that's used alongside INH and or rifampin. Adverse effects for this one, all vision. We really want to focus on vision. Optic neuritis is the main issue that can occur, and they can have decreased vision in general and a decreased ability to identify and distinguish red and green, so like color blindness. So really for this one, the important thing to remember is that the drug should be discontinued if optic neuritis develops. Streptomycin is a second-line drug. This is one of those aminoglycosides from, I think that's unit 2 or 3, where we talk about antibiotic medications. This one, just like, um, sorry, gentamicin the other one in the class. I'm thinking about gentamicin. It can be nephrotoxic and ototoxic. This one is given IM, and because it is like gentamicin, you have to obtain peak and trough levels to make sure that it's at a safe dose. In general, some close contacts will get prophylactic treatment. Same with those with latent TB, as I mentioned. There's a few bullet points there about the active therapy process, but the important thing to remember is that it is a very long process. Whether you have latent, active, whatever the situation is, treating TB is a beast. It requires very, very strict medication adherence because these bacteria can adapt like nobody's business. They could be drug resistant, multi-drug resistant, extremely multi-drug resistant. It can be very, very difficult to treat these. And the issue is that medication adherence is super, super difficult in the populations that are often most impacted by tuberculosis. If you go into a prison or a homeless shelter or even just, homeless population on the street, it is very, very difficult for them to have that equitable access to medication in the first place, but then to ensure that adherence to take it every day, it's just really difficult. Um, so an option for these patients is direct observed therapy, which is where a nurse or other healthcare provider observes the patient taking the meds every single day. So they go to them and take them and watch them take the meds, just to prevent that resistance and promote adherence. We're almost done, guys. We'll be done early today. There's just like three practice questions maybe, and then we'll be done. True or false, patients on isoniazid can take vitamin B6 to reduce the risk of developing neuropathy associated with treatment. Awesome, you guys are all correct. Yep. There is a risk of that neuropathy with isoniazid. Vitamin B6 can be taken subsequently to reduce your risk of that. A patient on rifampin calls the clinic worried about her urine being bright red. What is the appropriate response? You guys are correct. That one is, I keep sending me backwards. That one is B. So definitely know like what side effects I guess are normal versus which ones would be cause for concern. Which of the following is a concern unique to ethambutol? Okay, this one is C. Optic neuritis is for ethambutol. Perfect. The other ones are all concerns regarding tuberculosis medications, just kind of matching which one to which medication. Alrighty, guys, we're done pretty early. This is all I had for you guys. Hopefully, this was helpful. Per usual, I will email this to you as well as the practice quiz that I made. It's another 8 or 9 question practice quiz. If you could do both of these QR codes, I would super, super appreciate it. If you only can get the one on the left, that's also totally fine. Like I said at the beginning of the session, I am continuing tutoring for this course and Patho 2, so your feedback means a lot to me. Um, Let me go ahead and why did this do this? I don't want to. I want you guys to be able to get the QR code, so I'm trying to go back. Okay, there it is. That works. Awesome. Yes, if you guys want to go ahead and if you haven't already, throw your emails in the messages so I can go ahead and email this to you guys. No worries if you hopped on late. Um, yeah, that is all I have for you. So you're welcome to go ahead and stay for some questions or go ahead and log off. And best of luck on your guys' exam. Let me, yeah, you're welcome. Good luck, guys.